Thanks, Phoebe, and welcome to everybody who's been here before, and welcome back, shall I say, and welcome to any newcomers. We're going to look at the elbow, but primarily just lateral epicondylitis. The elbows, there's so many other little things which can go wrong there. I mean, your golfer's elbow, you've got your tennis elbow, lateral epicondylitis, a bit of a misnomer there. I'll explain that in a minute. Olecranon bursitis, collateral ligament damage, everything like that. There's a similarity in all these things, that there will be a big inflammatory response often, but not always totally inflammatory, especially in the case of lateral epicondylitis. I'll explain why. But we'll go through the etiopathogenesis. We'll look at the intrinsic and extrinsic factors. We'll look at associated problems which can mask themselves as lateral epicondylitis. Or often, should I say, really, they're really comorbidities as well. So it's sorting out what is the primary factor in causing problems here. And we'll just have a quick look at sorting it out, what you do with it. I mean, we all have various ways of treating epicondylitis. The biggest problem I have in my practice is patients who've come again to see me and they've never sorted out this problem. They've had it for years, and they've had they come and say, well, the last time I had an injection by the doctor, and it's come back. And this is a frightening thing for me, because all the research has really shown, as it does with a lot of tendons, the big problem with this corticosteroid injection is it will work effectively to reduce pain, but for a very short period, up to 5-6 weeks. And after that, you're really stuffed, because the effect of a corticosteroid is really to actually cancel out the healing process. And so it will never get better. Also, you've got the weakening of the tendon, as you know, people have 3 of these, 4 of these. And as far as I'm concerned, it's a bit crazy. If people have to have injections, we'll just discuss very briefly PRP, plasma-enriched platelet injections, which have shown to have some effect in the cure, curing the problem. But really, the corticosteroid thing is a massive problem. So what I'm going to start off with is just some slides, which have been given to me by the manufacturer's ASA, and we'll go through those. We're going to stop at only 10 of these, because it will go on and talk about other things, but we're just going to look at the lateral epicondylitis. Okay, so what I need to do is share my screen here. Right, let's show, hopefully we can get onto it this way. Right, just help me out, guys. Are you seeing the slides here? Yeah, brilliant. Okay, right, we're looking at the elbow here, and my machine is not working. Let's see. Okay, lateral epicondylitis, the etiopathogenesis. Right, just before we start, lateral epicondylitis, okay, implies an inflammation with the itis. You will really, in most of the people you'll see, literally a vast majority, there won't be an itis as such. There will be some probably form of inflammation going on in there. But so much of this is concerned with degeneration of the tendon. And so let's just go through this. It's a disorder of the wrist extensor muscles on the lateral epicondyle. We've got, 8 of these extensors all going to this area on the outside of the elbow, and what we're getting an overload and repetitive trauma in this area, which is starting a fibrosis, micro lesions of the involved tissues. Right, now initially that might be a little itis, a little bit an inflammatory response, and if you can get a younger person who's got just the itis, Very, very quick to sort this out. The big problem we have with this lateral epicondylitis is it is usually a lateral epicondylopathy. It's a tendinosis, tendinopathy. Well, we've got the degeneration, and you've got a big problem with these areas, like a few of the tendons, rotator cuff, Achilles, not great vascularity. So we've got a real problem in here, trying to really repair it. Just remember, the tendon just doesn't have an inflammatory aspect going on in there. It's actually deformed. You have a deformed tendon, and what we really need to do is give it the best opportunity to remodel. So we'll be talking about the laser, and I'll be showing you how to use the laser, but it's so important to use this in conjunction with a correct eccentric loading program to actually try and separate the collagen and bring it back to where it should be. Among tennis players, 10 to 50% have tennis elbow symptoms. Let's really forget too much about tennis players. It's a little name which has been given to it, but you can get this anyway. The most common cause is biomechanical. These are the Italians that said this, a biomechanical mistake. Incorrect form, performing the backhand is what it really should say. And other intrinsic factors which you'll get with tennis elbow from tennis, wrong or small handle, bad racket cushioning, the intrinsic factors, weak muscles of the shoulder, elbow and wrist. Other causes, bowling, baseball and golf. But if we really consider what is the cause of this problem, it's not just tennis players, it's people doing anything which is manual labor related, really. Heavy tool use, repetitive tasks, people on the computer all day using the mouse. All these things are causing little micro lesions, and then they're not getting repaired, and we keep on doing new work on them, so it never repairs. And this is where the tendinopathy comes in, where we get the deformation. The collagen, which should be aligned nicely like that, has become all misshapen, doesn't have its tensile strength, so we keep on breaking it again. And then we get the deformation from the tenocytes, the long thin cells becoming big and round, held open by cytoskeletons, and we get pain from a neural ingrowth as the neovascularity occurs. And then you got the pain. You will also have some inflammation every time we do something which breaks this up again a little bit more. We've got inflammation on top of the neural ingrowth. So it's a bit of a nasty thing, and I'm sure lots of you will have experience of having real problems trying to sort this out. The laser is phenomenal in helping with this situation. So we talked about the intrinsic factors, the extrinsic factors, but intrinsic factors, inflexibility of the tissue. The more we actually damage this, we're changing the collagen type 1 to collagen type 3. It's inelastic, it's not flexible. Muscle weakness, which I did mention, but really consider muscle imbalance as well. We've got the problem on the extensor mechanism, but if you've got a real complete imbalance with the flexor system, you're going to have problems. More pressure will be going on these extensors. Decreased vascularity, as I told you about in that area, and which leads to the tendon degeneration, decreased healing process. And the other thing is, you might well, on top of this, get an inflammatory enthesopathy, where a big enthesopathy, big problem with things like psoriatic arthritis. It's where the tendons join into the bone, and we have massive pain there. Moving on. Right, clinical assessment and diagnosis. I don't want to dwell on this too much, because you'll all know the rough tests of what we're doing, but point pain directly over the middle part of the lateral epicondyle, increasing during wrist extension against resistance. One of our tests will against resistance, will resist the wrist extension, and you'll get some really bad pain there. Now, this is quite an important thing we're coming up to here. It's often associated to radial tunnel syndrome, which is the most common cause of lateral reflex pain, and that is present in 10% of epicondylitis patients. I'm going to show you the exact figures. I'd probably say it's a lot higher. What we'll do is when we actually test for lateral epicondylitis, this is something which must not be missed, because the radial tunnel syndrome, which can be totally confused with posterior interosseous nerve problems, is a major problem. It will cause an awful lot of pain all down the forearm. There's a big difference between radial tunnel syndrome and posterior interosseous nerve syndrome, diagnosed clinically, is that the posterior interosseous nerve syndrome will actually lead to some motor weakness. You won't get motor weakness generally on radial tunnel syndrome, but it's exactly the same. It's compressive forces right through the supinator muscle, through an area called the arcade of Froese, I think it's called. And this is where we probably also need to look at loosening off all the muscles. And that's why when we treat with a laser, we'll come across what we're talking about, the global approach and the pathology settings. And it's very important to look at the global approach as well, especially for something like with a comorbidity of radial tunnel syndrome or even posterior interosseous nerve problems. Looking at the radial tunnel syndrome is a set of symptoms that include fatigue or a dull aching pain at the top of the forearm with use. You won't get the motor weakness. That will be really from posterior interosseous nerve. It's the same thing, it's the radial nerve going through the arcade of Froese. Symptoms are caused by pressure on the radial nerve, usually at the elbow. The radial nerve is one of the three main nerves in the arm. All stuff you know this. At the elbow, the radial nerve enters a narrow tunnel formed by muscles, tendon, and bone. This is called the radial tunnel, and there's a little area in the supinator muscle called the arcade of Froese, which is a problem where the pressure really comes down. What are we going to do with lateral epicondylitis? Well, or lateral epicondylopathy, should we say? Police, okay. Police, what is police? Well, it's protect, it's optimally load. We don't want to carry on doing what we're doing to it because it will just cause further problems, but we want to load it. Remember, tissues adapt to stress as you put them under. If we don't do anything with them, they will not repair. We've got to load them, but let's optimally load them. Okay, then you just got your ice, your ice, your compression, your elevation. Exercise mechanics correction. With the tennis player, he'll probably be using too much wrist work when he should be using more of the arm. I know, speak to your tennis coach about that, but then we can actually advise them as well. Stretching of these tissues, massively important. Splint, we can use a splint as well. The two main kinds of splint we come across is just up on the elbow here, the band to actually to take the pressure off the common extensor origin. By putting pressure on here, we offload from the common extensor origin, and it will have some effect in reducing pain. It's not going to sort the problem out as such, but it will reduce pain. But the other thing is, with the band here, I would always recommend somebody don't use the band if you've got radial tunnel syndrome going on there as well, or pin entrapment, posterior interosseous nerve entrapment, because that band is going around here in an area where we've got the supinator muscle, and if we compress that further, you're still going to have the problems. So that is part of your diagnosis, okay? The splint, which is probably, in my mind, the most helpful, is what they, do you remember the cock-up wrists? So you're actually keeping the wrist a little bit in extension, and so you're putting less pressure on the common extensor origin. We want exercise to increase range of movement. We want muscle strengthening. or should I really say muscle balancing, but strengthening and balancing so important. So if we're trying to strengthen these extensors, do not forget these flexors, because if we get a terrible imbalance, then we're going to have further problems. Okay, and then the big one here, MLS laser therapy. Well, we'll go through what the laser is going to do in a minute, but correct diagnosis first. Okay, so we've got to work out, is it just the common extensor origin, or is it an tendinopathy there, or is it the arcade of Froese? Is it the radial tunnel syndrome as well? There are other things which I'll mention as well, which we must always look at when we're doing our diagnosis. Ultrasound can be used for a bit of diagnosis. Again, it's helpful. I think figures of 75% specificity. But again, it is very much reliant on the user skill. So I don't use ultrasound for diagnostic stuff myself. I go on a clinical diagnosis, and I trust my clinical skills to do that. And correct treatment. So assessment of the patient, the parameter settings, which we'll go through on this machine, how to help with that patient, and therapeutic protocol. So we'll use the laser as it tells us to use it, using our brains a little bit to probably change the settings if we need to. What's quite important here, just to look at, I don't know if you can see my cursor, so there's 7 or 8 tendons all coming to this area, but the 3 which are most involved usually are the extensor carpi radialis brevis. Actually, that's going right up here. That should actually stop a little bit shorter, I think. The extensor digitorum communis and the extensor carpi ulnaris. And those are 3 ones which are mainly involved in this, this problem. Okay. Right. What we talked about in laser with ACER Class 4 MLS system is the global approach. Okay. And again, we talked about radial tunnel syndrome. It's actually not at the problem isn't at the epicondyle. That's why the global approach is so important, because what we always do is we'll do a global scan over all the muscles which are connected with this problem. In this case, we'll be looking at all the extensor mechanism, but I'd be also looking at some of the flexor mechanism. And then what's not, well, actually it is, they brought it up here, a little bit on the biceps, but here, much more importantly, up on the triceps, because there are some trigger points up in the triceps which can mimic this, or just exacerbate the lateral epicondylitis symptoms hugely. So we'll find those and we can deal with those at the same time, or just after we've done the pathology treatment. But it's giving the scan first, filling the tissues with photobiomodulation, increasing vascularity, filling oxygenating all the cells by activating the mitochondria, which will start the creation of ATP, which will start the activity within the cell. It basically makes these 6 cells better. And then on top of that, if we're dealing with the correct physical therapy solution, which we would use, and with that as well, increasing vascularity of these areas, we'll get a pretty amazing change. The trigger points I mentioned, the ones they've given me here are mainly in the forearm, in the flexor and extensor mechanisms. But I'll show you another one later, really in the triceps, which I think is probably even more important. And just look for these trigger points and treat them. On this laser, there is a fantastic, and I really mean fantastic, a fantastic little setting for trigger point for dealing with trigger points. And it is phenomenally effective. And it will, within settings of 20 seconds, it will reduce the pain monumentally. So the global approach, one thing, we deal with all the tissues around the area. When we're actually dealing with the, especially on a joint condition, always look for the optical windows. There are certain positions where we can open up or close the joint. We want to open up these joints so we can actually get the laser going right in that area. There's just these a couple of things. Test for the lateral epicondylitis. I don't need to go through these. There's stuff which you will all know, but all I will say, that's going to medial epicondylitis, what I would always say is, the one which they haven't mentioned here, is just always test for radial tunnel syndrome, which would be having your arm extended and resist supination. Supination, remember, when we were taught years ago at college to university, how do you know the difference between supination and pronation? Supination is turning this way because you can hold a bowl of soup like that. Okay, and pronation is going that way. So it's resisting supination. And if you're getting pain in the forearm from that, then you've probably got an involvement of that. Another one for testing for the radial tunnel is just resisted middle finger extension. And that will be very important as well. So that is what we're going to show you, just the slides. I want to get on more today with just really messing around on this machine. Couple of things I would like to say when I start and I'm not going to go through the whole examination here, well I'm not, but on the examination, whenever I do what the person comes in with saying they've got the elbow pain, is it tennis elbow? They might well be right, but I will always start my investigation. I'll look at the cervical spine because we can get referrals down there. I always rule out the cervical spine. A quick Sperling's test is usually very good. I will look at the shoulder because we can get referrals down there. But really, I think the biggest thing which we should test before we go into any treatment is look for these trigger points, because the trigger points are just phenomenally important to sort out, because they, particularly these ones in the triceps, they will actually refer right over that lateral epicondyle and cause all sorts of problems. It can mimic that pain, and you might have nothing wrong with your, it's doubtful, but you might have nothing wrong with the lateral epicondyle itself. So let's get on and have a look at the settings of the, let me just stop this. I should be back in the room now. Let's have a look at the computer, the laser. Right, okay. Once you've switched your laser on, you'll come up with, sorry, let's get this down. Okay. You'll have got, first of all, saying loading, and then just go into the body charts here. Right, now, we've got the body here, very simple. You've got pathologies which are set out for you, so we can use those. Before we go on, actually, I just want to bring your attention back to a very important thing. If you do have the laser, if I can find it here, just mess around with your idiot's guide. This is just quite brilliant, because if you've got any confusion, we'll get straight away knowing exactly what we've got to do. It starts off with talking about laser therapy, the difference between laser therapy and MLS therapy, biological effects, effects on the tissue, effects at a systemic level, blah, blah, anti-inflammatory, anti-edemic effect, the biostimulating effect, general suggestions. What they talk about, which is something too important to know for when we're doing our settings ourselves, in a very, very acute pathology, you know, 24 hours to 48 hours after this has happened, we're going to use pretty low frequencies, up to 100 hertz, maybe a little bit more. In acute pathology, we're going from 100 to 300 hertz. It's all down on this little thing here. It's a rough guide, okay? And in a chronic pathology, this is where we start putting the frequencies much higher. So, and treatment cycles, it says 2 to 15 sessions. Really, again, for all users, just remember 3, 2, 1. Okay, we find the best effects happen cumulatively when you've got the person 3 times the first week, and you'll see that treatments will only take up to 11 minutes. You can book them in for a 15-minute session. You can treat them with the laser as long as they've got their own stuff which they need to do at home. We can do it in 15 minutes, but 3, 2, 1. 3 times the first week, twice the second week, once the third week, and then continue as you need to. And you'll start seeing some phenomenal effects with this. Okay, but just going back onto this machine here, if we go further through here, it comes onto here. Every condition, let's shoulder. We talk about the scan phase. You can probably see that scan phase, and I'll give you a rough guide of where we're going to scan. But that is what we're talking about, the global approach. We're going to scan all the tissues around the area, and then it's got an area for trigger points. We can deal with the trigger points before the pathology or after the pathology. It doesn't really matter. But then the pathology setting, if you've just got the handset, this is it here. If you've got the MPHI-5 with the Charlie head, this is what you can use. But just go on the pathology points. I'm not exact points. You use what you find. Okay, that's the shoulder. It's always the same, every page. So here we are on the elbow, scan phase, pathology phase, trigger points down here. Everything you do, the wrist and hand, scan phase, pathology setting. So just use this little book. It's very, very helpful. So let's get back into the machine. Okay, here we have the body charts, and what we're going to do is we're going to deal with the elbow. Oh, those who don't have the Charlie head, you won't see this little thing here with the wand on there. That's only there because we can actually just swap that over. We can do completely different settings on the Charlie head, use it on a different part of the body or the same part of the body, but use it all at the same time. But we're just going to go back to a 1. So it'll just automatically come up with this. We're going to press on the elbow here, and it's just got a few little pathologies there. But forget the pathologies at the moment. What we're going to do is we're going to scan. Okay, now we're going to scan, press on there. This all goes much lighter, so we can't actually do anything about this at the moment because we're on the scan phase. It comes up automatically acute, but if you remember what we talked about, this is rarely lateral epicondylitis. Is never really a true epicondylitis. It is generally more chronic. It's something which has been building up, and we've got something in a bit of deformation of these tissues. So on the scan, I will generally be going chronic. Now this will make a difference because if you'll see on here, it's going 300 hertz, 4 minutes, 25%. But as it's chronic, we're going to put a bit more power in there and a bit more hertz. So it goes in there, automatically comes up with 500 hertz, 75%, 4 minutes. We can change these things if we want. We can go up to 100% if we want, but I wouldn't. I just stick on there the first time, and then we can see what results we're getting straight away. So we start off here, the scan phase, 500 hertz, 4 minutes, 75%. Again, I'll come back and I'll explain to you this CPW thing later, but that will change the joules involved in here completely. On the joules setting here, it's saying it's 103.3 joules, okay? It's giving you joules totally over the area where you're scanning because we're not keeping this still. When we're doing the pathology setting and we're keeping it still, it will show you joules per square centimeter because it will show you exactly what is going into that one area. Anyway, what we do is we start this. I'll start it in a second because I'm just going to change the camera here. I can change onto here. Okay, and there we have our patient. Just for those of you who are worried why she's not wearing a mask or anything and I'm not covered in gear, this is my wife. So there is no danger here. But with what's going on now, there's massive infection control going on. So we have to be very careful. But just, I don't want to be covered in stuff while we do this. Okay, so here we are. What I'm going to do is, there's the little green button on here where we're going to press start. Now, if I just move that out there, okay, before we press anything, probably the most important thing you must always do with a class 4 laser is use these things, the glasses, okay? Infrared light you cannot see. When I press the button on here, you'll get a little bit of redness. That's from an LED showing you where it's going, but you cannot see infrared light. It can also bounce off all sorts of metal objects, and without you, if you're not pointing in your eye, it doesn't really matter. It will still probably cause damage to the retina, and we don't want that to happen. So, just to show you what's on here, I've dressed up like Bono, and I'm all ready to go here. I wanted to move this here because when I press start on here, you'll see this just flashes. Let's press. Okay, but it doesn't get active there. So it's just showing it's going, but we're ready to start it. We'll just press this little button on here and we can get the scan going. Okay, so I'm going to bring this over here so we can see the patient and get that arm in position here. Remove dangerous stain out of the way. Okay, and let's move this laser a little bit closer. Right, what we talked about was really doing the scan on all the extensor mechanism, probably a little bit on the flexor mechanism, and really on the triceps. These are the big areas that we want to be doing that. Okay, so it's very simple. All I do is I press the button here, on the top of here, just press that button and you'll see it starts. Now let's just switch the lights off so you can see it a bit more clearly. Okay, so what we do is we start it, bang, and you can probably see it's on there. Now what I'm going to do is I'm going to put this on the tissues and I'm just going to go nice and slowly over all the tissues around here. I'm really going to look at this, where the radial tunnel will be going through this supinator area. Can you turn your hand over a bit now? Go on more of the flexor mechanism. Nice slow strokes. Just no real big pressure down there, but it's on the skin and just moving nicely over the whole area. This is going to go on for 4 minutes. I'm not going to do the whole thing, but I just want to show you roughly what we're doing. Very important, triceps. Don't forget these triceps ever. You'll probably find there's a number of trigger points in here, and we'll look for those in a minute. Round the area itself, up and down. And this will go on until it's the 4 minutes is up, when it will just automatically switch itself off. So instead of having to wait the 4 minutes, I'm just going to stop it now, but it'll go bing like that and just switch off. So there we are. We've just stopped that. Okay, I'm going to go back onto the screen. So that was 4 minutes, didn't take long at all. And what I'm going to do now is I'm going to go straight onto the pathology setting. I'll look for trigger points afterwards. But let's go on to, back onto the screen. So what would have happened here on this screen, it would have continued down. You can probably see we did probably 1.5 minutes. It's still 2 minutes, 33 seconds to go. If I just actually start this again, you'll see what's happening, okay? It's counting down the minutes and it's counting up the joules, okay? and that will go right down to naught, and it will just stop itself. So it'll stop like that. Okay, so it comes back here. Okay, what we want to do now is we've done the scan. Let's go off there. Now we want to do the pathology. Okay, so what we're saying is it is tennis elbow. Okay, tennis elbow comes up here. We can't actually affect the chronic or acute situation in here where nothing will happen. Okay, but it comes up with a setting automatically for what they would use for tennis elbow. What it's saying is the hertz have gone up very slightly. It's 700 hertz, 7 minutes, 50%, 6 points. You can probably see as well here, it's saying 6.69 joules per square centimetre. Right now, it's no point in me asking you a question because I can't hear you and you won't be able to answer me, but I would normally say, what is the problem with this condition that we've got? Well, we've already discussed it. We're saying this is very rarely just a lateral epicondylitis. This is usually a deformative situation and is much more chronic. Now, we could actually whack so much more power into this, it'd be unbelievable. Well, I'll show you what we could do. But what we just want to do is probably just go a little bit more power in here, just to increase the joules. At the moment, it's 6.69 joules per square centimetre. Total of 126 joules, 0.084. If I just go up to 75% on here, on the intensity, I've gone up to 9.76 joules, and we've gone up to 183 joules in total. Okay, we could go up to 100%, 241 joules now, which is 12.82 per square centimetre. We're getting quite big here. You can, if you increase the hertz, it'll very slightly increase the joules. I mean, we're at 12.82. If I went to 800 hertz, it's gone 12.9. Makes very, very little difference. So I bet the settings is they've got 700. I'd leave it there and I'd mess around with the intensity. But if I was a complete nutcase and I wanted to whack as many joules as possible into this person straight away, I would press the CPW. Now that CPW, if I press that, that is talking about the one of the widths of light, which is the 808 nanometers of light. And instead of it being frequent, it's going to be completely continuous. So if I press that, you'll see this frequency will disappear. Okay, if I press that, bang, and it's disappeared. It's just gone CPW in there. So now we're continuous with one width of light. But look what's happened to this joules. We've gone to 26.13 joules per square centimetre. That was originally at 6.69, I think it was. And I've put it up to 26 joules per square centimetre. There is a slight problem doing this. It doesn't matter, even it's a very chronic problem. Sorry, let me just come back to here. There's a problem with this because you're liable to get what we call a rebound effect. It's like anything, if you put too much power into something, you will get a reaction which it doesn't want. If it was a very, very chronic situation, I wasn't getting changes as I built it up a bit, I probably would use the CPW, but only after having tried it a few times first, because if you get this rebound effect, what effectively happens is the patient, instead of feeling an immediate improvement, will probably say within 24 hours, say, God, you know, I actually felt a bit worse after that. What did you do to me? Well, all you did was be stupid and put far too much power in at too early a stage. And you can build up and you'll work out having a protocol by asking the person, how's it feeling? I mean, whether we need more or less. But the rebound effect will have taken place. Tell the patient, if you ever get that because you're stupid and you've gone CPW straight away, tell the patient, don't panic. I guarantee you within 48 hours, that will be back exactly where it was and we'll start again. But we shouldn't get to that. But we've got the ability, as I've shown you on here, that we can increase the joules, we can increase the power, intensity, everything going into there to get an even bigger effect. more is not always better. This works, I find, honestly, female clinicians are so much better than male, because male think bigger is better. The more we smash this, the better we get it. No, it doesn't work like that. Not always, anyway. So let's go back to the screen. Where are we? This one, and then I'll change it again to the treatment. But what we've done now, we put it on the tennis elbow. You'll probably see on here, they're giving you a rough guideline of where you're going to do the pathology settings, okay? Yes, on the lateral epicondyle, but then all coming down the forearm. We can probably look at the forearm a little bit as well, but I would not just follow this completely blindly. I would actually probably do a bit more around 4 of the 6 points. I would actually stick on the really sore areas just around this elbow, and a couple down in the wrist as well, in the forearm. They've got one on the wrist as well, which I very rarely do use, but I do stick more around here. Now, at the moment we've got it, so we're going to give the person a rebound effect. We don't want that, so let's go back. If you're ever in problem thinking, where was I? Just come off here. Okay, just go back in from the start. Tennis elbow gives you the original settings which the manufacturers recommend. I felt we should go a little bit more. Okay, so it's a chronic situation. I'm going to go up to 75%. What we're going to do now is we're going to apply this to the patient. There are 6 points. I think halfway through here, I'll just show you what happens, how it just stops itself. But there's 7 minutes, 6 points, which means my maths isn't very good. That's probably 1 minute 10 each point. Okay, we press start, and the thing will be going red on the end there, but that gives me time to change the computer. And let's go back to here. Right, there's my patient. And what we're going to do is we've already ascertained that well, she doesn't have a problem, but if we get right on this epicondyle, if I press on there, so go ooh, no, go ooh, terrible pain. Oh, yeah, okay, okay. And you probably find often in the ECRB just a little bit down, very, very sore, and then there might be a bit of pain down here. But what I'm going to do is, this is where she's jumping around like a good one here. And I'm going to get this on the point, okay, and I'm just going to leave this on here. Let's see if you can see that a bit better there, bring that around there. Right, I've got it on this one point here, and I'm probably going to mess around with a few points around here. Now, I'm going to have to leave that just there for about 1 minute 10 seconds. You can see my thumb is nowhere near the button or anything, because you'll see what will happen. I should have timed this. One minute, 10 seconds is a long time when you're counting it. Very long time. Right, it's just stopped itself completely because it's done the 1 minute 10 seconds. It will have changed from 6 to 5 now, we'll say, but we're going to go another point there, okay, and we'll do all the points we want to do, which are causing the most pain. Okay, I'm going to stop it here because I just want to show you what's going on here. Actually, I'll keep it going, but I don't let me just show you this. As you can see, what's going on here is it changes. We're on the 5th point now, so there's 4, 3, 2, 1 after that, okay? It's adding up the joules in total, showing you what the intensity we're using, and it's counting down the time. So when that gets to 440, I imagine it's going to stop again, and we can probably wait 20 seconds, or 10 seconds, whatever, 700 hertz. I reckon it will stop at 440. Yeah, stops, and it's gone down to 4 now, and we carry on and so on until it's finished, and then that is our treatment completed as far as the pathology goes. Going to get off. Trigger points. What we're going to do is we will assess and in the forearm to see any taut bands which pain. Trigger point is where part of the muscle's in a contraction. Acetylcholine has got sarcomeres where it's in the contraction. You're getting a base products, lactic acid, etc. And you get these very, very specific referral. You want to release those areas where it's in a contraction. And we have this little setting here, just here, trigger points. Okay. Trigger point, let's go off the pathology setting. We press the trigger points. It comes up acute. Leave it acute because trigger points by nature are things. It's giving you 20 seconds, 25%. Okay, simple. All we do is we press start. Press start. We go back to the page. And what we do here is
Paul, I think you've frozen temporarily. You still there? Hello?
let's start 20 seconds and we'll retest it. Now 20 seconds is not a long time, but it's a long time when you're watching like that. Okay, we're going to get in there, retest again. Is that as bad as it was? Still bad? Still sore. Okay. I would pretty much guarantee 2 or 3 of these, the pain will actually reduce or gone completely. But look for trigger points in the forearm and trigger points in the forearm on the extensors, on the flexors. Okay, a little bit better. Okay. And so on. 2 or 3 of these and the pain will go. It's phenomenal. Okay, I'm going to stop it there because it's 20 past. I just want to show you what we've got here as well. Let me put the lights on. Right. With this system here, actually let's leave that up there. What I've got here is, as you can see, here's the computer, here's the laser, okay, with the handpiece, the wand as we call it, but this is on the trolley, and we've got the Charlie head, and the Charlie head is this fella up here. Now, the Charlie head is basically exactly the same as the handpiece, but there's 3 of them, which are focused to hit about 20 centimeters away on an area. So we'll actually cover a massive area, treat all at once. And we can speed up treatment times hugely, or we can deal with another pathology at the same time. And I'll just set this for the tennis elbow. What is very useful about this in the present climate with social distancing, I think, there will be a number of patients who want to come back and have physio, but they don't want physical contact. And so a nice little way of doing this is, there's the patient there. I'll show you the settings in a minute. I'll show you how easy it is. But what we'll do is, we'll get the Charlie head down here. You just turn that around there. Get exactly on the area. It should be 20 centimeters away. There is a little piece of wire which comes with this, which shows you exactly how, but I don't want to sting the patient. That is 20 centimeters. That is perfect. Okay. All I'm going to do here is I'm going to quickly go onto the Charlie head. I'm going to go on the elbow setting here. There's elbow. 7 minutes, 50%, 3 points. And what it's recommending is round here and round here. Okay. So what we do here, you've got your glasses on, good. We start. Okay, and then we just press on top. Here is a little button. Bang. Got that on the point where we want to go. And we go off and have a cup of tea. You see this is pretty effective. You see where it's coming over that whole area. Okay, and then we will move it down when it'll stop itself, and then we'll just stop itself, and then we'll move it down here, and we'll get on this forearm area. And so on. Right, I'm going to stop that. Lights back on. Right, let's come back to here. I never have enough time to do all these things. Right, now we showed you what the laser, how to use it. It is so incredibly simple. We can always adjust it. The more chronic, we can always put the intensity up or the hertz up, or if you wanted a little bit longer to get some more joules. I wouldn't. I'd just leave the timing very much. Just increase intensity. Or you can go to CPW if you really want to chuck loads in there. But you are getting masses in there. And just be careful when you're doing that. What I said to you was we need to actually employ a correct strengthening, muscle balancing program. As far as the strengthening goes, I'd just like to make the point that evidence shows that we really want to get, especially in a tendinopathy, which most of these things are, we want to get eccentric loading going. Now, generally, there's a big problem with eccentric loading. It can be very, very painful. The great thing about this laser is, you know, people use shockwave for the tendon stuff. It works in a completely different way. That smashes the tissues more, breaks them down, get a new inflammatory effect, and tries to get the repair to going there. What we're doing is we're repairing the tissues here by oxygenating the cells at a cellular level. So that repairs the cells, but at the same time, with the two widths of light, with the 808 nanometers, it's actually causing the tissue repair by creating the ATP. It's also mechanically warming up the tissues a little bit, and you're getting movement of the edema, so reduction of edema. But also, it's getting all the NRL-P10 anti-inflammatory proteins to bind onto the ATP. So you're getting a massive anti-inflammatory effect at the same time. So you're getting a reduction of pain from that, but at exactly the same time, it's sending in 905 nanometers of light, synchronized, at 25 watts, which is just huge amounts of power. It doesn't burn you, it doesn't cook you, because it's on for, it's super pulse, on for a nanosecond, off, on, off, on, off. So the tissues heat, cool, heat, cool, heat, cool. You won't really feel the heat. If you left it on for 20 minutes, you might feel a topical warmth. But what it's doing is sending this massive amount of power at 905 nanometers, which actually works on the inhibition of the pain pathways. Now, with physiotherapy, with using shockwave, all these things, our biggest enemy in physiotherapy is pain. Pain is a muscle inhibitor. Pain stops us wanting to do things. Pain makes us think, oh, if we do move that, it hurts like hell, therefore it's causing me tissue damage. Well, on the contrary, we need to get these things working. We have to get, the laser itself is not the answer. The answer is exercise with the laser. Now, what happens is, if you're smashing somebody with that shockwave, really, we look at it on a VAS scale, you know, from 10 to 5, people aren't just going to want to move at all. Below 5 to 3, they might think about it. 3 and below, they will do. With this, they could be up at, you know, 8, saying my pain is 8 out of 10. We'll actually reduce the pain straight away with the laser, with the effect it has on pain pathway inhibition, and we can get them doing this eccentric loading, which they would never be able to do beforehand. So it's a fantastic thing. Eccentric loading is we're just getting the muscles working as they're getting longer. So we'll get the weight in here, lift your wrist up, and then slowly let the extensors go right down. Don't lift it up with the weight in there. Let go of the weight, bring your hand up, put the weight in, slowly let it down. Again, remember what I said about muscle balancing. If you're doing the eccentric work on your extensors, do it as well on your flexors as well. We don't want one side all strong and the other side all weak, and you're going to cause a further problem. So, look, I've had an awful lot to cover. Hopefully that's made some sense. I'm going to stop there. If there are any questions, please let me have them straight away.
Hi, Paul. Thank you very much. That was really interesting. There's a couple of questions came in early on. Claire has asked, how far does the laser penetrate through tissue?
Right. Well, previously lasers, your class 3B lasers would be good for topical stuff if you stayed on them for about 10 hours. This does put so much power in. There is a therapeutic window between 750 nanometers, 750 nanometers, and really about 950 nanometers, where we get this depth of up to 5 to 6 centimeters where it will go in. So it goes massively deep, providing all the power right through in that width we've got there, which is the Charlie head massive, the one lower, but it's going right through up to 6 centimeters. So we're getting all the effects very, very deep. So yeah, that's the simple answer there. It's phenomenal. The MLS laser works on the two widths, 808 nanometers and 905 nanometers. They are both within that therapeutic window. Some of these lasers go above 950. Once we get there, the graph will just go straight up to the top. And then what's happening is, because they're not super pulse like this one, and they're putting in lots of power like this one, but what it's doing then is just spreading over topically into the watery dermis tissues. And if you leave that on there, and you have to move this really quite quickly, if you don't move it, if you keep it still for any period of time, literally seconds, you'll cause thermal damage, you'll cause necrosis of the tissues, and that's a big problem. When we're going to class 4 lasers, we're talking about huge amounts of power. With this one, it is 100% safe. We cannot cause the tissue damage because it's in the right therapeutic window. It's also super pulse on the 25 watts, which the 905 nanometers is sent in. 25 watts is just going to cook you. This doesn't, because of the accurate super pulsing, which is on off. Tissues are getting they're getting all the chemical and mechanical effects without the thermal damage.
Awesome. And Claire's also asked, is it okay to use the laser over moles?
Yes, yes, it is. The only thing you have to be really quite careful about in terms of using on a mole, you don't want to go and have any treatment on moles or anything. And if this mole has been changing colour and become more crossy or anything like that, that's just a matter of sense. Because there is a number of, but a general mole, yes, absolutely 100%. It's also safe on people who've had cancer who are in remission. There's no problem. Where we don't use it is on somebody who's got an active cancer and having treatment, because we're talking about rapidly dividing tissue, and we don't want to speed up this because this is working at a cellular level to activate the cells. So we don't want to use it on an active cancer, but in remission it's fine. If it's a normal mole, absolutely, 100% fine. If your mole has actually been changing color and getting all weird and crusty, don't come and see me for a treatment on your elbow or your shoulder. Right? Get straight down to the GP and make sure the GP knows what they're talking about, and get them to refer you up for an oncology assessment. And then you can have it removed.
Thank you. Someone else has asked, what's the recurrence rate of well, any problem, but specifically, I suppose, lateral epicondylitis after laser treatment?
Well, this comes down to how you treat it. If you don't treat it, as I'm telling you, basically what we're trying to do is we're trying to remodel the tissue. So understand what the problem is. We are remodeling this tendon. How are we remodeling the tendon? We're using the eccentric loading. That is naturally going to pull the collagen like that, okay? What it's going to do is start a protein synthesis within the body itself, which starts, it activates the integrins, which fly between the collagen and the cells. They knock on the cells, which become big and round. It starts stimulating the nucleus, protein synthesis starts the recreation, and all the neural ingrowth will go away. We're remodeling that way. So technically, you could actually, just with an eccentric loading, there is evidence to show that that would work. But what we're talking about here, we're talking about deformed tissue, degraded deformed tissue. Now, if we want to get this eccentric loading to work really well, we want to change that tissue. By using the laser, we're changing, just by massively infiltrating the cells with the ATP, we're actually starting, we're making the sick cells healthy. If something's healthy, it's able to repair itself much better. So they will actually respond much better to this eccentric loading, and you will get the change of collagen as well. The phenomenal effects of changing the collagen type 3 to type 1 again, the elastic collagen, is what we want. Now, if you do this correctly with your eccentric loading, with your laser, what's the recurrence? Well, my whole philosophy on seeing patients is I don't want to see them again, certainly not for that same problem, okay? And I would say 100%, if it's done correctly, you will sort it out, because you're not just getting rid of the pain, which happens so much with physios. We can do treatments which will reduce pain and stuff like that. What's the point? You've got to actually repair it. You've got to make it better. You've got to remodel this stuff. And the way to remodel it is stuff with your physical modalities, your exercise, everything like that, plus having at a cellular level changes which will let that adaptation take place and improve it. So once it's done, it's fixed, and that's the whole thing. And that is a massive, it's a massive seller for your business as well. Because people might say, oh shit, I used to go back every 6 months or every 2 months on my elbow. Now I don't have to go back. But I tell you what, Mrs. Smith, you've been having problems with your elbow. Go and see Claire, whatever, and she'll sort it out. She's got this amazing machine.
Thank you. One more question. Shaquille's asked, does the laser damage any of the surrounding tissue?
No. Damage? No. What? It comes back to the always I get this. No, it doesn't. All it'll do is it improve the vascularity and oxygenation of all the cells. It'll just improve all the cells around there. Where you've got to be slightly concerned is when we look at the very few contraindications, one of them being cancer, but another one which I say this every week. I've never come across an exact case where this has happened, but what we're recommended, well, what we're told is with contraindication against using it over the growth plates on long bones, on children. The simple reason is we're activating cellular activity. And so quite simply, if you activate this, there's lots of evidence to show that this could happen, but if you're activating the cells at the growth plates, what you're liable to do is actually make those growth plates think they finished growing when little Johnny's only 9 years old. So if little Johnny grows up with, you know, one long leg and one short leg, could it have been due to that laser? You just don't do it over the growth plates, but use it elsewhere on the kid, all over, you know, but not on growth plates. And that's just knowing your anatomy. Know where the growth plates are. Don't use it on those growth plates. Anything where you're increasing cellular activity, which is on a pregnant lady. So, you know, you might be doing it. So I don't use it on pregnant women for the very simple reason we are talking about this dividing tissue and we want the baby to be born perfectly okay. You know, if you're activating the cells in some way which could lead to something which is, I don't know, a deformity of some kind, it's very, very, very unlikely. But there is, just using your brain about this, if there's a possibility from a rapidly dividing tissue being activated like that, then we don't do it. And that's what it comes down to.